What is inflammatory bowel disease? For this audience of purely cardiology and then general practitioners, I just said that I wanted to mention that it is a chronic inflammation of the gastrointestinal tract, and it occurs due to dysregulation of the host immune responses that lead to the chronic intestinal inflammation in a particular group of populations who are genetically susceptible. We have two different types of inflammatory bowel disease. One, ulcerative colitis, where there is a mucosal ulceration in the colon, which is more common, and other is the Crohn's disease, where there is inflammation is transmural and also causes both small and large intestinal inflammation. Both of these conditions differ in genetic predisposition, risk factors, and also clinical and endoscopic and histological features. Though both are clubbed under inflammatory bowel disease, their behavior is little different. What are the various ways of presentation of ulcerative colitis? Naturally, it's a colodic disease, presentation with diarrhea, rectal bleeding, passage of mucus, pain abdomen, anorexia, nausea, and vomiting. It also affects the non-luminal organs like joints, eyes, skin, oral cavity, and other organs, like the causing other fever and weight loss. So, not necessarily ulcerative colitis patients do see the gastroenterologist. They also can be seen by the other specialists involving the joints and the eyes, like that. So the predisposed risk of cancer in these patients is 18% at 30 years when it is ulcerative colitis. How do we diagnose ulcerative colitis? By history, by physical examination, and lab testings like stool examination and blood examination, and we have imaging technology like a plain X-ray of the abdomen, barium series, and imaging like MRI and CT scan. Of course, we cannot do away without a luminal examination, either in the form of sigmoidoscopy or colonoscopy. How does it actually manifest? What is the pathophysiology of ulcerative colitis? In healthy state, the mucosal immune system is mediated by anti-inflammatory mediators and the balance between the pro-inflammatory mediators. The mucosal immune system ensures that the balance occurs between the pro and anti-inflammatory mediators and thereby allows an effective defense against the luminal pathogens. So this is what is going to happen in the chronic mucosal inflammation in inflammatory bowel disease, which leads to more of pro-inflammatory cytokines like TNF alpha, interleukin 1 and 6, that results in the colonic tissue damage where there is more of pro-inflammatory mediators. It actually, the inflammation is naturally occurs in two phases to simplify to the core. One, the first phase is the vascular phase, where there is an activation of the mononuclear lymphocytes and there is an entry into the mucosa. And the next is the intestinal wall phase, where there are activated lymphocytes release the cytokines, resulting into mucosal inflammation, and then leads to the signs of inflammatory bowel disease. It is the vascular phase that is the key factor in initiation and migration of the lymphocytes, which actually occurs by substances called integrins and cytokines that lead to firm adhesion, transmigration, and migration of the lymphocytes. The overall lymphocyte population is expanded in ulcerative colitis, and there is something called lymphocyte trafficking, and their journey from the vascular space to the gut tissue is regulated by a series of adhesion molecules like selectins, integrins, and ICAMs. Post-trafficking, the lymphocytes facilitate proliferation, gene expression, and apoptosis or survival pro-inflammatory mediator release. So all these things leads to a cascade of initiation of vascular phase to luminal phase, and then the inflammation will continue. This is the second phase of the inflammation, where the NF-κB, the receptors play a key role, where there is a stimulation by the lymphocytes by free radicals and microbial antigens that is leads to NF-κB activation, Activation of NF-κB leads to the release of various inflammatory cytokines and inflammation of the colon. Why we are discussing this in detail is that the mechanism of action of the latest drugs targeting on this basic concept. The inhibition of the NF-κB is the particular importance and considered as a putative target intervention for ulcerative colitis. So, if you see where exactly NF-κB receptor in ulcerative colitis is acting, means it is inflammatory stimuli, that is the cytokines like IL-1 and TNF-alpha lead to kinase release, and the activation of IKK and IKB alpha phosphorylation and activation of NF-κB, and that leads to the NF-κB translocation into the nucleus. That leads to the activation of genes encoding the inflammatory mediators. This is the simplest I could make it to make you believe that NF-κB is actively involved. Then, keeping these factors in the back of your mind, how the treatment options are made available. We know this pyramid where there is a base of the pyramid, we have the simple anti-inflammatory drugs like 5-ACRS-alpha-salazine. Next we have prednisolone, immunomodulators like azathioprine 6-MP, biologics, and of course we have surgery. So the antibiotics and probiotics and the aminosalicylate like mesalamine, olsalazine, balsalazide, the corticosteroids act at the different levels as I depicted in the diagram here. Some of the medications act in the luminal way, some of the drugs act on the epithelium, and some like corticosteroids act like anti-inflammatory acts inside the lumen in the lamina propria. There are limitations of the current individual agents like 5-ASA. We have the disadvantages of hematological parameters, hypersensitivity reactions, liver abnormalities, renal abnormalities, and of course some people have gastric problems and diarrhea and headache. So this is the one drug which need to be taken for a long time to keep the maintaining the remission. So a long standing medication is likely to cause some problems. We do have corticosteroids, though they can be given for a short duration in a severe disease. They also can impair the glucose tolerance, suppress the adrenal secretions, and they make the person susceptible to infection, lead to weight gain and osteoporosis. Other immunomodulators like methotrexate also are used, that also causes alopecia, myelosuppression, pain, abdomen, headache, and of course anti-TNF-alpha molecules, which are the latest biologics, where there is a reactivation of latent infection. In a country like us, there is a latent infection activation of tuberculosis, cutaneous reactions, systemic and hematological malignancies in a long term are also known. Further, there is a clear and unmet need to target alternative pathways which are involved in the inflammatory process. So there comes the need for looking beyond the available drugs which are acting at different levels. So the emerging options which are coming here are something called curcumin. Though the name is curcumin, this is just the same haldi what we use in a day in and out in our cooking preparations. Ayurveda mentions curcumin in several disease entities where it is given mixed with food items. The biologically active phytochemical compound obtained from the rhizomes of Curcuma longa, that is what is haldi, it has been identified to have diverse properties like anti-inflammatory, antioxidant, anti-proliferative, and anti-angiogenic. So what is the mode of action of curcumin? If you recall the same diagram which I mentioned, it prevents the activation of NF-κB at this level, and also it prevents the translocation into the nucleus of this substance. It also known to prevent the release of inflammatory mediators. So it at one shot, a drug is known to act at the core level. When you add on to the mesalamine in a mild to moderate ulcerative colitis, it improves both clinical activity index and endoscopic index. It suppresses the morbidity associated with ulcerative colitis. Adding curcumin to mesalamine is superior in inducing clinical remission and endoscopic remission. So this is a really novel way to improve the action of mesalamine. As of now, we don't have any medication to improve the survival, improve the efficacy in mild to moderate disease, though we have options of plenty in moderate to severe disease. And it has been shown to be safe and a promising agent in the treatment of ulcerative colitis, though we need to have much more clinical trials. Of course, it can be used in the clinical practice at present. It also has been used in these clinical trials for the prevention of relapse and also maintenance of remission. It has been shown to be effective as an add-on and maintain remission and prevent relapse along with mesalamine. That's what I said. You may say that why to buy curcumin? We'll take the conventional curcumin, go to the kitchen and buy and then swallow it. But it may not be that simple. And the raw haldi or curcumin, what we mean is a hydrophobic polyphenolic compound. It is poorly absorbed and it is undetectable in plasma, and it does not reach the systemic organs and tissues. So the clinical trials are carried out with the conventional curcumin, have to use high doses and the poor GI tolerability. So it requires that the essence of the curcumin has to be isolated, and you cannot use it just like that as a raw form. So for a drug to be effective and tolerable, curcumin formulation having a good bioavailability need to be used. That is what is called bioenhanced curcumin. The technology what is available today is a novel formulation of curcumin using self-micro-emulsifying drug delivery system has been developed, and this technology provides nano-sized hydrophilic droplets of curcumin which facilitates better absorption, better tissue penetration, and then it delivers the multimodal action. To complete the talk, there are different molecules as of now still in the pipeline and are available. The target action is given at various levels here. The molecules like natalizumab, vedolizumab, alicaforcin, tocilizumab, ustekinumab, apilimumab. So these are so many other drugs which are available, which should be available in course of time with much more refinements. So to just say one or two lines on each drug, like natalizumab is a humanized monoclonal antibody against alpha-4 integrin. Vedolizumab is a humanized monoclonal antibody against IgG1. And these two drugs are already there, and many more drugs are going to come in future. Thank you very much.